So, what I was just explaining is that we're going to start doing audit review every 2 months. We're going to do 2 hours, or it's going to be a 2-hour session. And this, what we're going to do is I'm going to pull some reports, I'm going to pull some topics, and we're going to go over some different stuff. I hope everybody's gotten a copy of the protocols. If you have not, complain to Andrew.
It's all his fault. He didn't make enough to attend the workshop.
I know everybody else.
Are you the protocol master now?
No, I just have the.
He's got the one with the hyperlinks on it, so if you want a copy with the hyperlinks where you can press the link and it'll go directly to the program.
I've got a hard copy.
Oh, do you want a digital copy with the hyperlinks?
If you want to, yeah, I'll just do a hard copy.
Okay, if you can send one in. So,
Actually, now that you bring that up, I think I had a copy before they changed. Wasn't there some changes made?
yes,
The copy I have is the old one.
the hard copy is not.
It is not?
No, you have the current hard copy because I gave you the hard copy.
Okay, so that is current.
That is the current hard copy, yes. You have the current hard copy because I gave you the current hard copy.
Could I get a hard copy when I'm in there next, since I start in October?
Yep. Are there any questions about the protocols that anybody has?
Can I sell protocols? Whoever needs them.
Did you make enough money already with all your side hustles?
No, I work for the county.
Alright, so,
You don't get paid at Santa's workshop?
alright. So we will go over the runs first, and then we will go over the various and sundry things, topics that I chose for this month. So the first run, so we're reviewing July's runs. First run was written
I can start on the 25th.
the 13th.
Start from the back.
This was the front. Oh, I guess it was the back, but that was the front that I picked up. So, unknown problem, person down. So this person, Medic 1 dispatch via radio for a female patient who's unresponsive, possibly from a bee sting. Medic 1 responds with lights and sirens 9625 West County Road 715 South while responding. Dispatch gives updates as follows. Unresponsive CPR started. Family member is there by herself and she is there by herself. CPR still in progress with some gasping type respiration. CPR still in progress, no longer breathing. Arrived on scene, placed AED, no shock advised, also administered Narcan, no comment there. Upon our arrival, we find the patient being tended to by Lovett, Montgomery, and the Sheriff's Department. Glucose device is placed with compressions restarted. An attempt was made to locate IV, but none were found. IO is placed in the tibia. The tubing is flushed and attached to the IO, needle secured with stabilizing device. Marrow is observed. Flushed the site. Deputies on scene advised that they have a bottle of hydrocodone that appears to be missing pills. Epi and Narcan are given via the IO. No apparent signs of anaphylaxis. Patient is on the monitor with the pads and shows a Brady PEA. Epi is given. Suction is brought in and used to clear the airway of vomit. Patient is placed on a canvas stretcher and moved to the cot. Once the patient is on the cot, a 7.0 tube is placed and lung sounds are heard. In the lungs and the stomach sounds are clear. End tidal reads 24. Vomit comes up the tube. Attempt to use portable suction, but the battery is quit. Move the patient to Medic 1. While moving the patient to Medic 1, I asked the family about the timeline of what happened this morning. They advised they got a call from patient 1022. They said the patient sounded weak and stated she felt like something wasn't right. They came from their home to check on a patient, unknown how far it is, but 10:22, they talked to her. 10:26, dispatch, I mean, not very long, said the patient, when they arrived, patient was found down and appeared to be, take her morning medication, collapsed on the floor of the kitchen. Family states they don't know much about the patient's medical history. I enter medical one and do a pulse check and possibly feel a pulse, request the unit bagging stop and still feel a slight bradycardic pulse, aspirin given. Start transport to Schneck. During transport, 3 more epi are given. VFib rhythm is observed during pulse check and shock is delivered. Arrive at Schneck and patient care is turned over to staff and trauma to patient report given at bedside.
The doctor wanted to know why the hell was Bob there, because they're dead.
That was ours.
That was ours. Well, it's Schneck. So, I mean, that's pretty par for the course. I mean,
This call was?
Yeah, those are the ones
That's where I was off that day.
yeah.
I remember that.
I mean, so the only thing that I would say is don't use the word I in your report.
Don't use
But I'm referring to me.
Yeah, so you use the term this paramedic. You don't refer to yourself in the first person.
Why is that? English told me otherwise when I was in school.
It's just, that is the way that you don't, when you're writing reports, you don't use the word I. That's,
I've never had that trouble.
that's,
It's the first time I never heard that.
yeah, you shouldn't be using the pronoun I.
All right, I'll use we.
Can I use that?
Yeah, you shouldn't be using I, we, this crew. That's just pretty, universal about report writing. That would be the only thing that I'd say about the report, but, I mean.
Yeah, that's a 20-year habit, it's gonna be tough to break.
No, yeah, I understand. But,
Huh?
so,
I'm an undisclosed person.
you did all you could, and, well, Schneck didn't like it.
Does
Oh,
Schneck
well.
like anything?
Schneck doesn't like anything.
Go read a Roger Brown report.
What?
Go read a Roger Brown report.
Yeah.
He thought I was bad in that one.
So let's see, 727, heat exhaustion. Jennings County Medic 1 dispatch for someone that is altered arrived to find a 55-year-old woman slumped over on a zero turn, was able to wake patient a bit to get information from her. Patient stated she went out to her garage around 2000 to 2030 to 1000 Bs and felt nauseated and vomited a couple times. Patient said she felt like passing out, so she sat on the mower, and it took her a couple hours to finally get to the house where we found her. Blood sugar 85, blood pressure 123/77, 98 pulse, 100% of room air. Drew labs and flush, started a saline bolus, pretty standard stuff. We went through a real hot stretch there where we saw a lot of heat-related emergencies in a whole range of age patients, and no one was exempt from it. We're in a little milder weather now, and hopefully that'll start going away. That was appropriate. So here's let's see, stroke CVA. This was an odd one. This was Mel's. This was a real strange one.
It was different.
This guy was, a few days from graduating the State Police Academy.
Yes.
And Medic 5, so there are, and we'll talk about different ways of writing reports. Everybody has their own ways. This is the Chart D method, which is a very comprehensive and thorough method. Especially people who are new, getting an EMT class and stuff like that, just starting out your career, you will look at different chart methods and you will see that there's a narrative method, there's a chart method, there's a SOAP method, and you can kind of pick the way that you like to do yours as long as it gets the point across. There's no wrong way to do it. So, C, Medic 5 called to respond to METC for an emergency updated to possible stroke by ISP. H, 21-year-old male having stroke-like symptoms beginning 17:10 as memory loss, slurred speech, tingling in hands and fingers, and blurred vision. No medical history, no meds, no allergies. A, patient was found alert and oriented, skin pink and dry, pupils equal and reacted to light, experiencing aphasia, could understand everyone, but could not speak clearly or put into words what he wanted to say. So, expressive aphasia is the term for anyone who didn't know that. Like Mel said, bystanders stated that it started when they were running through a scenario and he could not remember information. Patient could not recall mother's phone number. Patient is said to have had a thick tongue, but his words were not clear when spoken and was witnessed having a near syncopal episode. Patient was becoming frustrated because he could not articulate what he wanted to say when he was responding. Bystanders state that they spoke with patient's mother and she had similar occasions with the same symptoms and it was related to high blood pressure. Patient was able to articulate that he felt good but could not speak appropriately. R, a stroke scale is performed on the patient, had equal strength, grip, and no facial droop. Patient did not complain of any pain, no headache, nausea, vomiting, no shortness of breath. Blood sugar was 119, asked if he could walk, and he was escorted to the ambulance, and he boarded the ambulance without incident. In ambulance, patient placed on blood pressure and pulse oximeter. Patient blood pressure was elevated but continues to deny headache, nausea, vomiting. IV access obtained. Blood draw was attempted but would not draw, but no complication of flushing. ISP right along. Transport T, patient vital signs observed and remained stable during transport. Arrived at ER and patient unloaded, taken to bed. 6, able to transfer by sliding over. So he was ultimately admitted to 86th Street Neuro ICU, and they believe he did have a stroke. I don't know the final discharge result from 86th Street, but that was kind of what they were thinking, was that he did have a small occlusion, small vessel occlusion. Alright, so chest pain, non-cardiac, primary symptom. So this, it says primary impression, chest pain, non-cardiac, primary symptom, chest pain, cardiac. So it's kind of contradictory there, so just be careful about contradicting yourself. Medic 4 dispatched a 61-year-old female having chest pain. Medic 4 responded emergent lights and sirens from base. Upon arrival, patient is found sitting at kitchen table holding her chest, alert and oriented, GCS 15, normal color, warm and dry. Chest pain started last night, been intermittent, history of AFib, stroke, and ablation. Localized center of her chest, goes to her back and into her left arm. Described the pain as dull and aching, assisted to standing position onto the stretcher. Goes over vitals. Raised pain 6 out of 10, given aspirin, 12 lead EKG, unable to intercept. Due to out of scope of practice. So, and I think Brooke and I discussed this already, so the wording there is just a little bit unclear. So, okay.
Supposed to be interpret.
Okay, interpret. Okay. Attempt to locate IV access unsuccessful. Patients transported to St. Vincent Hospital, non-emergent. Monitored, becoming given Zofran. So, I don't know if everybody here everybody here with access to foam frat did the documentation one that Mike had asked people to complete. But in the documentation one, it talks about repeating things that are in checkboxes and stuff. So one of the things that you should not do is, like, the vital signs are on here, so don't put your vital signs in here, because even if you screw up one number, if this ever went to court and the number was one number was screwed up either here or here, they would tear that apart. So if the vital signs are here, don't bother putting them in here. Aspirin is administered. If you put the dosage here, just put aspirin administered. You don't have to put the dosage. Just stuff like that. Because like it talked about in that module, the more you duplicate, the more of a chance you could screw stuff up. Alright. JCEMS dispatch for well person check of assault victim, medic 4, when en route, no lights or sirens at dispatch address, while en route, law enforcement asked that we step it up. 61-year-old male standing in the parking lot, he was talking with law enforcement, cutting off his shirt to assess injuries from the assault. GCS 15, pink, warm and sweaty from being outside. Detective took pictures of the wounds while EMS bandaged and wrapped what we could, put his left arm in a sling, stated that he was knocked down by the assailant, hit and kicked about 15 times, lacerations to both eyebrow areas, and with swelling and minor bleeding. Patient was complaining of left shoulder pain, 7 out of 10. It was noted that the shoulder was obviously dislocated, maybe even broken. Upon the patient's request, he was being transported to CRH. He was loaded into the ambulance via the stretcher. His vital signs were monitored en route. 2 ice packs were used. Patient remained in Fowler's position. No change. Patient was taken to room 6. So, just same thing, but good job overall. Alright, so fall, treaty release AMA. So dispatch to a resident for fall, supine on the floor, pillow under head, hole in the drywall adjacent to the patient was noted. The hole was evaluated and found to be in proximity to a stud. Family stated that he fell while walking, struck his head on the wall, experienced a period of unconsciousness. Patient not on blood thinners. He began falling 1 week ago and he experienced 4 falls as of now. C-collar was placed. Patient was ACO ×4, skin pink, warm, dry, strong, regular radial pulses, speaking clearly in full sentences. Chief complaint, repeated falls, also complaining of chest wall pain, denying dyspnea, headache, nausea, vomiting, diarrhea, abdominal pain. Patient was in no obvious immediate life threat at this time. Rapid trauma assessment was performed. Negative decaf BTLS criteria through except for the following. Chest wall tenderness with deep inhalation and palpation. No deformity or crepitus was noted in this region. Swelling without bruising. Abdominal. ARQ. I'm not positive what that is. However, the patient and his wife stated that is normal. Chest rise was equal, lung sounds were clear in all fields, circulatory motor sensory functions were normal in all distal extremities, eyes were pearl. Vital signs, no, the patient was not presenting with shortness of breath or hypoxia. 12 lead with normal sinus rhythm, no XP noted. Field impression was a transient cardiac arrhythmia or rhythm disturbance and or PE. Patient was advised to allow ambulance transport to St. Vincent Jennings for further evaluation, but refused, stating that his physicians are schneck. So the reason I pulled this report was to bring up a couple of things. And I will go over the list later. We need to be careful about using abbreviations. There is a standard list of Medicare abbreviations. We need to be careful about using those. If we believe that there's anything cardiac going on, even if the family wants to transport them, and obviously I wasn't there for the conversation, but if we believe that it's cardiac, we should probably be suggesting they not go to Schneck, that they go to Columbus.
They was adamant about it.
I was saying, cause me and you were on that one.
Okay,
Oh.
alright, like I said, I mean, I wasn't on the run, that's one thing about audit review, we're Monday morning quarterbacking everything, and not on the run, so. What?
Nothing.
Got a shit-eating grin on your face?
No, not today.
But, yeah, I mean, so, that's why I'm just kind of going quickly through these, and I'll spend more on the, actual topics that I picked out, because, I don't like people Monday morning quarterbacking days, so,
So Tuesday's okay?
huh?
Tuesday's okay?
Perfectly fine. Well, because that's the day after Monday Night Football, so, we have to do it Tuesday morning.
Why is Monday Night Football on Monday night?
I have no idea.
Because that's the song that hangs in your room all the time.
That's right. Alright. Medic who responded with North Vernon Fire, 31-year-old male having difficulty breathing. Upon arrival found sitting upright on his couch. Vitals initially taken by fire. Prior to our arrival, you see them reported taking albuterol treatment about 15 minutes before EMS because he was coughing so hard he almost passed out. His children last week had pneumonia and he used one of their vials of albuterol. Cared for his sick children all week and felt as if his symptoms were very similar. Past medical history is only hypoglycemia, occasionally, but no medication was required. And he has anxiety, which takes Lexapro daily. No other medical history reported. Patient is allergic to Avalox. Only known drug allergy. Assisted during ambulation to cot by fire and placed on the cot. 3 straps, 2 rails loaded to ambulance. Once an ambulance, vital was taken again. Skin was hot and flushed, hot, flushed, and dry. Has a temp here. Breath sounds were very wet. So temp was 102.4. So I guess doesn't say. Oh, IV attempt was at 1757 in right lower inside forearm with a 20 gauge without success. So we had let's see, a 6-minute transport time, but we had a 22-minute on-scene time. So temp was 102.4, so what's one thing we could have done for the patient? Tylenol. So in talking with Dr. Qualls, he really, really wants to push using Tylenol for pain and fever. He wants more IV attempts for IV Tylenol for pain control out of advanced providers. He wants that as the front line as opposed to narcotics.
So what are we supposed to go off of what they tell us that they're 10 out of 10 and they're laying there perfectly fine? Or like our judgment for
What do you mean?
the Tylenol pain management?
Like if they're saying, like the patient I had earlier said her pain was a 10 out of 10 and she was talking like we are now.
The thing is that for acute pain, the studies show that IV Tylenol isn't as effective as narcotics. So whether it's a 10 out of 10 or a 2 out of 10, IV Tylenol will do the exact same thing. I had a guy with a femur fracture
Right,
that I gave IV Tylenol to, and it brought his pain down to a 1.
right.
So, regardless, you can use it. It's called to a 64-year-old female with elevated blood pressure. States that blood pressure was 267 over 136, I remember this dispatch. On arrival, patient is CAO ×4 sitting on the couch. Patient is pink, warm, and dry. States that her blood pressure spiked on her and is unsure why. She states that it's been an ongoing issue over the last couple of weeks, but tonight is the highest that it's gotten. She states that when it hit her, she got flushed and felt weak, and that it lasted for about 3 to 4 minutes, but she got better. She denies any one-sided weakness, chest pain, difficulty breathing, or vision changes. States that she was in her doctor's office today and gave her a new medication, but she hasn't started it yet. Checked blood pressure on both left and right side, and they were comparable. States that she's feeling all right at the moment, but is a little weak. She also states that she takes a water pill and that she has been outputting more than she has been putting in the last couple of days. Agrees to go to ER for evaluation. Patient is assisted to the cot and secured with straps ×3, rails ×2, is placed in medic 4. Once in the unit, we recheck vital signs and symptoms. Patient still denies any chest pain or discomfort. Due to patient's chief complaint, ran an EKG, showed normal sinus rhythm. Checked blood glucose. Started IV. Due to the possibility of being dehydrated, started normal saline running. So the reason I pulled this one, so initially when you have dehydration, what does the blood pressure do? Initially? Because, yeah. Initially when you have dehydration, the blood pressure will go up. It will start to bump. And also, as one of the articles that I pulled will show, certain blood pressure medications, because of the way they work, so certain diuretics, as you become more dehydrated, they will actually push your blood pressure higher. And so you will have people who will become extremely hypertensive like that, even though they are extremely dehydrated. So that's why I pulled that one. 63-year-old female, conscious, organ-oriented, found doubled over in pain. Patient relates she ate a frozen banquet meal for dinner. Shortly thereafter began having severe pain in her epigastrium going through to her back. Patient also complains of dizziness and nausea. Patient had gastric bypass in 2010, so she's unable to vomit, but she has been dry heaving. Patient is cool and diaphoretic, but her skin is normal color. The patient's abdomen is not extended, but pain is increased on palpation. The patient relates she's been having spells of nausea recently correlated with eating. Patient was placed on the cardiac monitor, and a 12-lead EKG was obtained with, which showed no ST change or ectopy. IV was established, 18 left AC. Patient was found to be profoundly hypotensive. IV bolus was administered with BP responding well as documented. IV Tylenol and Zofran administered as documented with the patient expressing significant relief of pain and nausea. Patient was transported to St. Vincent Jennings without lights and sirens. So, the only reason I pulled this is because Tylenol can be given regardless of blood pressure. Dispatched to a 16-year-old male having chest pain at Lakeside Pizza. Medic 5 responded emergent to the scene. On arrival, patient is standing next to a vehicle, leaned over into the seat. Alert and orient ×3, warm to the touch, normal color, diaphoretic. Grandmother stated the patient had been playing baseball all day and only drank water. Able to assist the patient in medic 5 and onto the cot. Once on the cot, the patient was moving around, stating he was cramping everywhere. Patient's thumb on his right hand was cramping along with his upper legs and left foot. Patient also had chest pain on the right upper side of his chest when he takes a breath. Patient is breathing approximately 30 times a minute. I am able to calm the patient and coach him to slow his breathing as we obtain an EKG. Sinus tach. Initial pulse was 155 before coaching. Gave him some fluids. Was put on nasal cannula. So again, that was during that real hot spell. He was out playing baseball. Was a heat emergency, and we'll talk a little bit more about those. Medic 3 dispatched to a sickness involving 80-year-old age female complaining of confusion, high blood sugar, not able to walk and slurred speech. Medic 3 went en route non-emergent and upgraded to emergent while emergent. Upon arrival, the patient's family met us outside and stated she was sitting in her urine all day, as she has not been able to stand and get changed. Also stated the patient is a non-compliant diabetic. The patient was sitting in her electronic wheelchair, alert and oriented. The patient stated there was nothing wrong with her and she did not have any medical complaints. The patient had urinated in her pants and the urine had an extremely strong odor. Patient's blood sugar was obtained and was 442 milligrams per deciliter. Patient's family stated before we were called her blood sugar was 350. Patient took 10 units of insulin and the blood sugar was still rose higher. Patient information was obtained. Patient had fallen early this morning due to loss of balance, but had no complaints of pain or injury. Agreed to be transported to ER for further evaluation. Patient was able to use her wheelchair to a garage where the cot was at, and patient was assisted from wheelchair to cot via assistance by fire and EMS. Secured, loaded, vitals obtained, IV. So, hello, sir. Just so whenever you're writing down blood sugars, just remember to put the units with them. Did a good job on the first one. The other unit, or the other one, there are no units with it. The correct measurement is milligrams per deciliter. I'm trying to think. I don't know if there's anything else. Dispatch for a sick person, medical correspondent non-emergent, no light sirens. Upon arrival, we were met by the patient's daughter and son-in-law. States the patient had been released from the hospital in Madison earlier today, seen for cellulitis and pain there. Had previously on antibiotics for infections. Our patient is sitting on the couch wrapped in a blanket in a robe, complaining of being cold and hurting. 85-year-old white female. The patient is not being cooperative with our instructions. After some time, our patient was able to be assisted into a wheelchair and moved outside to our